Assalamu alaikum everyone. So today I am here with my new lecture of surgical management of pain related to endometriosis. As endometriosis is a vast topic, so we are discussing it in sections. In this section we will only discuss the surgical management of pain that is related to endometriosis. I have still not discussed anything regarding the infertility because of endometriosis, so we will be discussing this topic as it is a vast topic in my upcoming lectures. Okay, so these are the surgical options that are available with us for surgical management of pain related to endometriosis, that is laparotomy, laparoscopy. Other procedures, the procedures which are undertaken via laparoscopy or laparotomy are excision of endometriosis, diathermic damage to the lesions of endometriosis, ablations, vaporization, interruption of pelvic nerve pathways. So the interruption of pelvic nerve pathways, they are comprised of group of procedures that are laparoscopic uterosacral nerve ablation and presacral neurectomy. Discussing few statistics. So the recurrence rate after surgery is 10 to 55% within 12 months of surgical treatment of endometriosis. Pain improvement at 6 months for first excisional procedure. It means if a procedure is performed for the first time. So after the first time performed procedures, within 6 months the pain improvement rate is around 83%. But for if the surgery is undertaken for recurrent endometriosis, so for second excisional procedures the pain improvement is only around 53%. That is why repeated surgery for endometriosis is not recommended. Okay, so these are the recommendations in ISHARE guidelines. Whatever reference I am sharing, it is from ISHARE guidelines and from Dewart's textbook 9th edition, chapter endometriosis. It is recommended to offer surgery as one of the treatment options for endometriosis associated pain. Consider excision instead of ablation. So this is an important topic. Excision should be considered instead of ablation to reduce endometriosis associated pain. Laparoscopic uterosacral nerve ablation is not beneficial as an additional procedure to conventional laparoscopic surgery for endometriosis. This means this is not recommended. PSN, that is presacral neurectomy, is beneficial for treatment of endometriosis associated midline pain. This means the centralized pain, centralized dysmenorrhea, as an adjunct to conventional laparoscopic surgery. But it should be stressed that PSN requires a high degree of skill, as laparoscopy is a highly skilled procedure and is associated with an increased risk of adverse effects such as intraoperative bleeding and postoperative constipation, urinary urgency, and painless first stage of labor. So all of these are complications of presacral neurectomy. So before considering this procedure, high level of expertise is needed, but this is a recommended procedure along with laparoscopic removal of endometriotic lesions if the patient has complaint of severe midline pain. Okay, so this is a picture of ovarian endometrioma that is diagnosed or that is being treated during laparoscopy. This is a chocolate filled fluid cyst. As you can see, it has a hemorrhagic look, and whenever it gets ruptured, a chocolate colored fluid is drained from the cyst. Surgery for ovarian endometriomas. So what surgeries are recommended for ovarian endometriomas? Cystectomy is preferred than drainage as it reduces risk of recurrence. So rather than drainage, cystectomy is preferred. Like you have to separate whole of the enucleate, whole of the cyst from the underlying ovarian tissue. Try to preserve as much ovarian tissue as you can and then remove whole of the cyst without leaving any part behind. Cystectomy and carbon dioxide laser vaporization have same effect after 1 year, so both can be considered during surgery. Okay, so these two procedures have been compared in many trials, and it is concluded that both of these procedures have same effect after 1 year. So if anyone has the facility of carbon dioxide laser vaporization, it can be considered as well. Ovarian failure, risk of ovarian failure after cystectomy is around 2.4% after bilateral ovarian endometriomas removal. Deep endometriosis of bowel. Deep endometriosis involving the bowel has been reported in 5 to 12% of women affected by endometriosis. 90% bowel endometriosis is located on sigmoid colon. So mainly sigmoid colon is known to be involved in deep endometriosis of bowel. So first of all, you have to do the triage. You have to exactly diagnose that what extent of bowel is involved by deep endometriosis, because whatever treatment you are going to perform, that will be affecting the quality of life of the patient, and different management strategies can be done. So you have to assess that whether medical treatment would be beneficial for the patient rather than surgical treatment if it has more complications. So you have to counsel the patient accordingly. The treatment proposed is excision and segmental bowel resection, which is recommended. Means you have to excise and also you have to resect that portion of the bowel which is involved in deep endometriosis, and ultimately anastomosis would be performed, or there could be formation of colostomy as well. Counsel regarding long-term risk and quality of life. Radical removal of deep endometriosis also improves fertility outcomes. So whenever we talk about the infertility related to endometriosis, it is always related to the residual tissue remained after surgery. It is recommended that whatever visible tissue you can see during surgery, you have to remove each and every of them. Even the newly formed blisters that are white and reddish vesicular structures, newly formed endometriotic vesicles present, they have to be diathermized or removed during surgeries. Laparoscopic approach is preferred due to shorter hospital stay and quick recovery. So the first priority of the form of surgery to be performed is laparoscopy. Endometriosis of bladder and ureters. Bladder endometriosis. For bladder endometriosis, you can go for excision of the lesion completely and primary closure of the bladder wall if it gets open. For ureteral endometriosis, excision after stenting the ureters. First you have to pass the stent in the ureters and then excise whole of the endometriotic tissue if the lesions are present inside the ureters. So you have to perform segmental resection, and you can do end-to-end anastomosis or reimplantation of the ureter by Boris or Swas procedure. So what is nerve sparing laparoscopy? This means you have to involve identification of pelvic splanchnic nerves and inferior hypogastric nerve plexus, which is providing all the nerve supply of pelvis, these two plexuses. Goal is to completely excise the endometriosis while avoiding injury to these pelvic nerves. So this means you have to spare any nerve injury, and by identifying these two plexuses, then you have to remove all of the deep endometriotic tissue in the pelvis. Hysterectomy is recommended or not? So this is a very important question. It is related to the age of the patient, to her own symptomatology, to her own preferences, that what treatment exactly she wants. So but the recommendation according to the Asia guideline is total hysterectomy with or without removal of ovaries and excision of all visible endometriotic lesions is considered in women in whom conservative measures have failed, and if she does not desire fertility anymore. Counsel regarding possibility of pain persistence due to residual endometriosis and centralization of pain is still after surgery. A woman can experience pain. This could be because of the small residual endometriotic tissue that could not be visualized during surgery, and centralization of pain because it involves certain nerve pathways like the pelvic splanchnic nerves, hypogastric nerve plexus. So still the pain could be there. So the patient have to be counseled accordingly. If BSO is done, bilateral self-induced hysterectomy, counsel regarding early menopause and need of HRT. So this is a very important thing. You have to immediately start HRT without waiting, and what form of HRT is recommended I will discuss later on. Okay, so are medical therapies recommended in relation to surgeries or not? So the recommendation is it is not recommended to advise pre-operative hormone treatment to improve immediate outcome of surgery with endometriosis. So pre-operative hormone treatment is not recommended to improve the outcome of surgery. However, post-operative hormone treatment, within 6 months is recommended to improve immediate outcome of surgery for pain in women with endometriosis if not desiring immediate pregnancy. So you have to give certain hormonal treatments which can involve the contraceptive pills or anti-androgens, and they can withhold the menstrual cycle of the patient if you have done the conservative surgery. And for 6 months you can stop her periods and she can have pain-free 6 months, and after that you can assess the outcome of surgery. So post-operative hormonal therapy is recommended, but pre-operative it has no any bigger advantage. What are the complications of all these surgeries related to deep endometriosis? Complications could be ureteric injuries, rectal injuries, fecal peritonitis, post-anastomosis leakage. If there is any bowel anastomosis or ureteric anastomosis has been done, or colostomy, ileostomy is performed, then there could be post-anastomosis leakage as well. And recurrence, which we have already discussed, that is around 10 to 55% within. HRT. What about hormone replacement therapy? Start HRT immediately in women undergone bilateral oophorectomy. Combined estrogen progesterone replacement therapy is recommended. So for giving estrogen alone, it is considered that it can activate the residual endometriotic tissue if any of them are remain. So combined estrogen progesterone replacement therapy is generally recommended. And if a woman we have left behind the ovaries, those ovaries can work for 5 years, but after that she will have her menopausal symptoms. So for her as well, when she starts having some menopausal symptoms, she can also have some combined estrogen progesterone replacement therapy. So that's all from my lecture. In the next lecture we will discuss infertility related to endometriosis. Thank you so much. Jazakallah.